Bismillahirrahmanirrahim. It's Dr. Abid Rafiq Chaudhary, pediatric intensive care consultant from Fatima Memorial Hospital, Lahore. So today we have a topic, factors influencing outcome in a prolonged pediatric ICU stay. So what are the factors which is important for the you know, getting patient out of the pediatric ICU once they are admitted for some reason. So these are the factors which really influence the morbidity and mortality of any patient admitted in pediatric ICU. And if you improve these factors, ultimate patient can get out of the pediatric ICU. So we'll discuss one by one. So I think the number one single most important factor in any patient in pediatric ICU admitted is the nursing presence at the bedside, and how much quick response, especially if the patient is ventilated already. And we really emphasize on the ABC that if patient is on ventilator or patient is on without ventilator on natural airway, so how quickly you can respond to patient if patient need airway management or intervention in any kind like need suction. So that is the single most important, and that factor depend on the good nursing care. Means appropriate troubleshooting at the bedside, and then obviously nurses they are going to call the respective physicians or the caregiver to handle the situation. Because nurses mostly they are at the bedside, and also in Pakistan mostly also the mothers are there at the bedside. So you have to be vigilant in any issue if patient encountered. Nurses they are trained well that they need to pick the change and inform the doctor on duty. So that is the most important factor. Suppose if someone is on ventilator and for something happen like patient is desaturating, then you have to do appropriately dope, which is the a differential diagnosis in any patient who who is on ventilator for some reason. So it is like displacement, obstruction, pneumothorax, and occupant failure. And in the next few slides, we are going to discuss in detail what is dope, and you have to manage appropriately ongoing pediatric ICU complication. And one of the most important complication in pediatric ICU is encountered is the on ventilator is the desaturation. It may be because of acute tube obstruction, dislodgement, or pneumothorax, or maybe ventilator is not functioning. We'll discuss in detail in the next few slides. The another important thing, if patient below pneumothorax, then you need to handle that situation. Maybe patient may have tension pneumothorax, or you have to do the needle decompression if patient is having tension pneumothorax signs while on ventilator, and end up by having a chest tube intubation. So the most important thing, relief of pneumothorax, that can also turn the prognosis on the better side. Because whenever you are long term ventilating any patient, so you have to be vigilant about air leaks. Infection control is very important, and there are three types of infection in pediatric ICU which can lead to a morbidity and mortality. It is ventilator associated pneumonia, catheter related UTI, and central line associated bloodstream infection. So for all these three infection, we have we use the mnemonic like 357. 357 means if you have a ventilator more than 3 days, you have a catheter, urinary catheter more than 5 days, and you have a central line more than 7 days, then the risk of morbidity and mortality is very high in these patients. So every time you walk to the bedside for a pediatric ICU patient, you have to ask yourself and the team whether you need to extubate this patient, whether you need this urinary catheter which is in place, and whether you need this central line or you need to get out. So because whenever you do these things daily in your round, you end up by intervening the patient, like removing the ventilator, removing the urinary catheter, and removing the central line, and ultimately that affects your prognosis, because then you are decreasing the infection rate in these patients. Another very important thing which we come across in pediatric ICU is the poor nutrition. So whenever you can feed the patient, especially enterally, like by NG or NJ, it is very important to continue. And every time you hold the feeding, or nursing hold, or any caregiver hold, like PG is on call, you need to know in the morning why the feeding has been hold, because a lot of times feeding has been hold for not valid reasons. So there should be some protocol about the nutrition, and as long as there is no contraindication for enteral feeding, you need to continue, because ultimate feeding is going to determine your prognosis for these patients. So it is very important to know that you have to strive to give feeding to these patients. And at the same time also you have to keep in mind that even if patient is intubated, they can have reflux and the risk for aspiration. So you have to give them a reflux treatment also most of the time. And also at the same time, if the patient lung is getting worse again and again, keep in mind reflux even on NG feeding, and sometimes you have to feed them NJ. And if they are not tolerating for some reason enteral feeding, then you have to do partial or total uh, parenteral nutrition, and for that mostly you need a central line inpatient. So as long as you don't put central line and you can feed enterally these patients, this is a better prognostic feature in any patient. Even they remain in ICU for like months, they can get out the ICU, because feeding can give them a better muscular strength, muscular endurance, and while they are on ventilator, they can do well. And there is a high chances of extubation also, as long as you can feed the baby while they are on ventilator. Another important thing, the weaning ventilator, you have to show patience and perseverance also. So go slowly, and the most important thing, you need to know that when you have to extubate your patient, and if you for some reason you fail one time, next time if you are extubating, you need to know that what thing you can do differently this time, for which reason you have failed last time, the patient. So you have to adopt a new plan every time you are trying to extubate, and always there is a risk for reintubation patient. So you need to maximize these patient the chances of extubation successfully. And a lot of times, if patient is like on 2 or 3 weeks of ventilation, then you have to go slowly, maybe from CMV to SIMV pressure support, and then maybe you have to use sprinting, like you have to give them alternative pressure support, SIMV with pressure support, CPAP, building up the nutrition, doing pulmonary toilet, and treating any pneumonia if they have, and optimizing the nutrition and muscular endurance, by giving a better nutrition. So you have to be patient in weaning ventilator, but at the same time you need to get rid of the ventilator as quickly as possible, so that because obviously, but remember, if you remove ventilator quickly and end up by having a reintubation, then you have a risk of in reintubation you can cause trauma, as well as you can have a ventilator associated pneumonia with every time you are reintubating the patient. So, and also you have to give them pre-extubation, like you have to fulfill the checklist, which there is another video already uploaded. Every time you are extubating any patient, you have to fulfill those pre-checklists before you going for extubation in a pediatric ICU, especially if the patient is prolonged ventilation, more than like 5. So a little bit about dope. Dope, normally also you can diagnose, because end tidal CO2 is zero, and dope stands for dislodgement. Maybe the tube go outside or maybe inside the right lung. It can be obstruction. If the patient is desaturating, may need suction. It can be pneumothorax or occupant failure. So how you are going to troubleshoot? So we have adopted the mnemonic for dope, like ARCD. So you have to do ambo bag, check resistance, auscultate the chest, and at the end maybe you have to do direct laryngoscopy. So first of all, when the nurse call you and you come to know that patient is desaturating on ventilator, you take the patient on ambo bag, and if patient is doing well on ambo bag and there is a better saturation and better chest rise, most likely your ventilator is malfunction. Maybe you can ask someone to fix the ventilator while you are ambo bag. But if your patient after disconnection from the ventilator and ambo bag is not improving and you feel resistance, so maybe most likely diagnosis is your tube is blocked and may need suction, and then you have to do suction with the normal line repeatedly, and as long as you feel less resistance and there is a better chest rise, you may have relieved the obstruction. But if you can, cannot, patient does not improve with embo bag, and there is no resistance to embo bag, then most likely your tube is out or patient has pneumothorax. So how you figure it out? So if there is a little bit improvement in the patient clinical condition and you examine the chest, clinically, maybe there is a unilateral rise, or there is a bulging on the pneumothorax side, or there is a obvious, there is no air entry on one side, then you may suspect that patient may have blown air leaks on that side. And if patient develops signs of tension pneumothorax, maybe you can relieve by needle decompression or later on chest tube drainage for that patient. But if you have taken patient on ambu bag and patient is not improving and there is no resistance, clearly patient may have, remove their tube, and the endotracheal tube, and you have to do direct laryngoscopy. And if you cannot see appropriately, then the tube going through the cords and it is out, then you have to re-intubate the patient. But the most important thing what I want to mention here, because please follow the ARCD, EMBO, resistance, chest finding, and direct laryngoscopy. Because a lot of times people, whenever any patient on ventilator, they desaturate, a lot of times PG, they assume that patient need reintubation, and they remove the tube and they try to put that tube. And that patient may not have a dislodgement of tube. Patient maybe have a ventilator malfunction or resistance because of obstruction or maybe pneumothorax. So you have to adopt this key as we have discussed, so that you, because a lot of time you remove the tube, patient is sick, it has a bad chest compliance, and you end up by having a difficult airway because you are intubating any patient emergently, and then you end up by having a lot of trauma, and also there is a risk of cardiac arrest because these patients, they are sick. So please don't assume that if patient is any patient on ventilator desaturating, most likely tube is out. There might be some other differential diagnosis as we discussed. So this approach is appropriate. Obviously, if you examine any patient and tube is in front of you and it is out, you will do direct laryngoscopy and you will try to put the tube in the larynx straightforward. But if you go there and tube is already there, so then you have to go with this embo bagging, checking the resistance and auscultating the chest, looking for pneumothorax, and and then later on direct laryngoscopy. If you adopt this technique, then there is a less chances of cardiac arrest, because whenever you are removing and reintubating these patients, other than having a risk of cardiac arrest, there is a risk of VAP also with repeated reintubations. So try to avoid that one. So what are the take home message? The factors which really influence the patient moving out of the ICU is the dope and the airway breathing circulation, needle thoracotomy and chest drainage if they develop air leak, meticulous infection control and nutritional support for their muscular and respiratory muscle endurance, a multidisciplinary approach, and also involvement of ID, especially if the patient has a prolonged ICU stay and infection issues, and weaning ventilation with patience and perseverance, because you have to go slowly, and if you fail one or two times, you have to adopt a different method to extubate that patient, and that depend on clinical experience and period guidelines. Thank you very much.